Okay, so Sandeep, are you still there to join our discussion?
Yes, I'm here.
Okay, so I think we have maybe 5 minutes for discussion because we are a bit behind the procedure, the program. Okay, so my first question for you is that in STEMI patients, is there any difference in between decide your decisions for DCB if you have a black erosions or black rupture?
Well, to be honest, I don't do that much imaging in STEMI to understand is a plaque erosion or a plaque rupture. To be honest, for me, it doesn't add much to the treatment. For me, I look at the patient, I look at the lesion, and then I decide. As I said, younger, because we are seeing often these in UK, 35, 40-year-old with MI, and in those patients, I want to avoid stenting, so I use more DCB. But again, elderly patients I use, and side branches. I showed you that case. I don't do that much imaging in STEMI unless the lesion is complex and I have to prepare the lesion more meticulously with calcium modification.
Okay, so this is my take. I think this is my take. I think we have to be cautioned when we drive this narrative of DCB. We expected this about 10 years ago, and we are confident, of course, DCB will increase in its market and in its usage. Evidence will show that the DCB will have a gain over time, where the stent, as we know, will continue to accumulate event year to year. So if we have young patients that live long enough, we will see more restenosis. Okay, if we do it in the very old people, we probably would just have about 5 to 10 years of horizon. But we talk about in Asia, like Malaysia, the mean age of patients are in their 50s. These patients have 20 years at least. So this is where I believe that the DCB will have the advantage. But we still have to be very careful because we don't want to go too hype and not careful with the science and the evidence. Yeah, we have to be careful, and we don't want to fall into the same issue with the BVS. So how do we see this in the future? I think I totally agree with Raj. There are many things to look at, and of course, when we look at it, how do we use more DCB in our practice while we build the evidence? We need to look at lesion preparation, and I think lesion preparation is understated. It is very important to relearn about ballooning technique. Yeah, and lesion preparation. So when we can do good lesion preparation, then we can increase the scope of DCB. Lesion preparation is not just the technique, but also the complex lesion. So the calcium can be better treated, the CTO can be better crossed. So all these will open up more opportunity for DCB. The second thing is deliverability. So this is where the industry have to improve the deliverability of the device. Yeah, and the deliverability is not just getting a balloon there, but also the deliverability, delivering the drug into the vessel wall. So this is where the binding technology and the diffusion dynamic of the drug is important. We need to see whether it can get the sirolimus or the paclitaxel, whether it's crystalline, whether it is amorphous, can get to the tissue level and last for at least 3 months for the suppression of the inflammation. This is a bit of a dream. I think we need to think the third one is the drug. For now, we talk about drug to suppress intimal hyperplasia. So it's for anti-proliferative. But we are not talking about anti-atherosclerotic. Whether eventually we'll have a drug that can actually be delivered into the vessel wall to actually alter atherosclerotic process. So that would be interesting. Last concern, we have to think about the trade-off as we move to DCB. Take, for example, bifurcation. People will say, I'm going to do less and less two-stent strategy. Would I lose my skills? Those who are expert doing it will say, no issue, I can still do it. Like riding a bicycle. You don't need to do a two-stent strategy every week. You can still do it. The question is for a lot of people who are learning, that they say, I don't get to learn it. What do I do? So this is where we have to think about simulator training. We need to bring in, the models and bring our, stands, and people can practice on them. They feel comfortable with the steps, so that we don't need to do two stand unnecessarily, but we're ready to use it where we need to. Yeah, so that's one thing. The last one is BVS. I think in the future there is still room to move from stent to BVS. When we expand the DCB so aggressively to more than 50 or even 80%, the market would be very shy to develop BVS. So in some way, I have actually a conflict of interest. I actually say, I don't want everybody to do DCB. I like to have people who still maintain the DES as their main use, so that the market will still see there is a 50-50 chance of developing BVS. So then those who are stent-based practitioners may then migrate to BVS. Those of us who do DCB may then have an opportunity to think about the BVS as a bailout. So let's see whether this is going to be true in the next 5-10 years.
Okay, so I want to hear some more opinions from other panelists. So Rustem, Dr. Rustem Dautov, what is your applying of DCB in your daily practice?
Well, Dr. Liu is my main mentor in DCB, and I'm trying to use it a lot. In Australia, average probably about 10% usage in PCI. Mine is about 35%, and it's in the last 2 years, so it's probably saturated all indications already. I like the way Sandeep described his indication for STEMI. I follow exactly the same. And as usual, listening to the words of Raj from Brunei, I learned from him a lot as well, especially lesion preparation, which is very important in DCB. It's different from stent, it's different mentality. And we essentially doing it in front of evidence for large vessels. We don't have it solid yet, but we believe in that. And we're leaving nothing behind. We are not causing major issues for those arteries. We can always come back, but we have to be very careful in large vessels, in proximal LAD, and probably avoid left main, etc. Evidence will come, and we will be ready for that. Yes, BVS also will help us. So it's an interesting part of PCI. It's less stent is better, I guess. Yeah, but stent will be still there for some indications.
Thank you. So Dr. Henry Chui, yes. How do you doing in between try to maintain the skill by two-stent technique, especially for the young, and make it more simple with DCB, like Dr. Liu just mentioned?
Yeah, I shift to use more DCB now as it's become a fashion in the world. So it's actually simplified the procedures a lot. And I also learned from Sandeep. He did come to Hong Kong earlier this year, and I went to Tuen Mun Hospital and learned from him. And a good lesion preparation is the key. He used a lot of like cutting balloons, scoring balloon 1-to-1 size, low pressure, really make a really good lesion preparation before the DCB. I think this is the key to success. And it did simplify the procedures and make the procedure safer for the patient. I mean, if the world is going to develop, usually the procedure is going to be simplified. And this is a trend. I mean, all the complex tools, then I agree that with the loss of the skill for the younger generation, maybe with the DCB. But of course, if we have the chance to do it, let the junior to do and you supervise would be the way to go.
Okay. Eng Han, would you like to give some comments and your views?
Sandeep, did you say something?
Yes. So after your comment, I want to add something. Please go ahead.
Okay, so I think DCBs are here to stay. The issue with the DCB nowadays is that, of course, the practice comes before some of the trials, especially in indications like large vessel, in AMI, in CTO. But I think there are a lot of promising data that's on the way for operators who have not yet widely adopted DCB therapy. I think from personal experience, as I started using DCB over the past few years, we need to approach it in a more thoughtful manner. As I would quote Raj, he said that this is more like a operator dependent type of technique. So the operator needs to be more involved, more thoughtful in creating dissections, in causing plaque fatigue, and in achieving less acute recoil by being more patient with procedures. And procedures are likely going to take much longer time in that inflation times are longer. And we also have to necessarily wait for some time before we take the final angiogram pictures, and not to mention that we should routinely plan to bring back the patient, whether it's at 6 months or 9 months or slightly earlier, depends on, it remains to be seen what's the best time to bring patients back. But at the end of the day, I think we're trying to achieve less stents for the patients so that we can let the vessels have retain its vasal motion, and also perhaps even enlarge with time. And that's a very promising future for drug-coated balloon therapy.
Okay, so I think, yeah, Sandeep, yes, last words
So
before we
short
close.
comment. Yeah, sure. So look, I think you all made a great point. It's a great lectures and great discussion. But I would like to throw a caution about this DCB, because we have not seen any trial as of now which has shown superiority of DCB or DS, even in small vessels. We have seen mainly non-inferiority. In fact, I had a patient last week, first time in my life, where he did a lot of reading. And he said to me, why am I getting a balloon which has been around only for a few years as compared to a stent which has got 20 years of data? And when he asked me that question, I couldn't answer it. I said, okay, look, I'll put stents, don't worry. So I had to put a stent in the chat because he asked for it. He said, look, I want something which has got data. So we had to be slightly careful about promoting DCB. Yes, we all love it. I use a lot. I'm sure you all use a lot. But as a general acceptance in the global community, we have to slowly introduce with evidence, with lesion preparation, with practice. Otherwise, we will face with a lot of negative results and complications that will put the technology down. One last point is that we are also setting up a STEMI trial. One, we are already part of the UK trial, and the other one is in the process of setting. So hopefully I will invite some of you to join the trial. Thank you.
Okay, I think we'd like to thank all our speakers, thank all the panelists, and thank you very much everyone to be here. And hopefully we have more DCB sessions in the future. Stand less, not stand free. Thank you. You need a picture? Okay. Stay with us. We're going to take a picture.